It's live. You can start now.
Shall I start?
Yeah, Kaladar, please proceed.
Sir. Okay, sir. Uh, Good morning, all. Thank you, Srinivas sir and Ganesham sir, for giving the opportunity to talk on X Forum. So today we will be discussing about anticoagulation strategies and ECMO support. So this is a very paramount, important thing when we start ECMO, because ECMO being the extracorporeal circuit with artificial endothelium, I can say there is no endothelium as such, but it's an artificial lining. So where the blood gets exposed, because of which there is a tendency the blood can clot. So we need to maintain without thrombosis, to prevent thrombosis, we need to maintain the blood uh, in a anticoagulation status. So that is the reason we need anticoagulation strategies. So what are the different reasons that we generally look at when we think of anticoagulation and ECMO support is one is acute thrombogenicity. When blood comes in contact, definitely the intrinsic and extrinsic pathways can get activated, leading to circuit thrombosis and decreased circuit life. And flow dynamics, there are always stasis zones where the connectors, pump head is there. This can create thrombus formation. So as thrombus formation occurs, there will be thrombus in oxygenator, which can lead to oxygenator failure. Being such an expensive thing, we cannot afford to go for a repeat oxygenator changes. And it can lead to systemic thromboembolism. So because especially in VA ECMO, the possibility that the emboli enter into the systemic circulation, leading to stroke and even other thromboembolysis, the mesenteric ischemia and all, the possibility is there. These are all different reasons why we resort generally to anticoagulation. So, other than that, despite there is a tremendous advances in ECMO circuit technology being since long time, still we are far from away from the endothelium that we generally deal with. The largest organ, I can say, in the human body, the endothelium. So generally, nitric oxide releasing satisfactory circuit design, still it is not there. So because of which the proteins blood accumulate, there are a lot of, as I was telling about. The complement activation and other components get activated, leading to thrombus formation. So heparin coated membranes are utilized, but still it doesn't seem to be totally eliminating the risk of coagulation. We will be dealing with these different surfaces, what are the different advances in subsequent slides. But yeah, definitely adding nitric oxide looks to be promising. It's long pending, happening, a lot of research being happening in this area. And especially another thing, what we are worried most of the times in heparin induced thrombocytopenia, will be dealing with it. So adding even direct thrombin inhibitors also being explored in this area. So coming to what are the different, generally the literature say bleeding and thrombotic events in adults is supported with the veno-venous extracorporeal membrane. This is an also registry analysis published in 2021. If you look at here, so the bleeding thrombotic events comprised of around 54.9% of all BTEs, like bleeding thrombotic events, and they were predominantly ECMO circuit thrombosis. So this is pretty common. So it can lead to sudden thrombotic events and sometimes high risk of inpatient mortality. Of course, bleeding and thrombosis both can be possibility. Balancing it is a tightrope, so balancing it is very important between bleeding and thrombosis. The reasons for bleeding are von Willebrand factor dysfunction, platelet dysfunction, fibrinolysis, consumption of coagulation factors. So the thrombotic tendency is because of, as I was telling, platelet activation, all other contact pathway activation leading to coagulation. So the tightrope, so we need to maintain very carefully between this bleeding and thrombosis. So it can also lead to a lot of hemodilution, dilutional coagulopathies. Sometimes the thrombin generation is, and platelets, they play a very important role. And they are the center of the coagulation, can say, so because of which thrombosis can happen. So the complications of thrombotic carry significant morbidity and mortality, as we were discussing. So it is almost 20 to 50% in different population. So when we generally encounter any normal situation where there is a normal coagulation has to be achieved. In ECMO, we generally tend to manipulate the coagulation pathway. Here, we don't want complete correction of coagulopathy because the thrombotic tendency is very high. That is the reason which will lead to circuit clotting and malfunction. That is the reason we kind of maintain some degree of anticoagulation most of the times for maintenance of this circuit. So when we generally think of coagulation cascade, generally it is, I can say it is not a cascade, rather it is a phase circle. Everything can happen simultaneously. So which one lead to the imbalance between all these, the platelet dysfunction, fibrinolysis, antifibrinolysis. This imbalance can happen because of which the tendency of towards bleeding and thrombosis can be there. If you look at in this figure, so where it is been clearly been shown where intrinsic pathway, extrinsic pathway, both are depicted in this picture. If you look at in extrinsic pathway, where it is being activated by tissue factor, which is caused by vascular injury or trauma, the tissue factor pathway inhibitor can be tried here. And then it leads to factor 7 to 7A activation, and then it leads to 10 to 10A activation, then prothrombin to thrombin, it will be converted. If you look at here, the 10A, this is one thing which is being explored by giving drugs like factor 10A inhibitors like rivaroxaban, apixaban, edoxaban, and betrixaban. And when then antithrombin 3, which actually inhibits thrombin formation. So it is like heparin, as we generally, this is the most universal across ECMO circuits that being used. So, and even low molecular weight heparin, both are indirect thrombin inhibitors. So they actually act through antithrombin activation, which will inhibit thrombin formation. So these are indirect thrombin inhibitors. And then direct thrombin inhibitors, these are less propensity to cause heparin-induced thrombocytopenia, something like argatroban, bivalirudin, disirutin, and dabigatran can be used. Bivalirudin is the one which generally being used regularly. And there is another antithrombin which activates fondaparinux, which is an indirect factor 10A inhibitor. It can inhibit 10A. So these are the different the antithrombotic agents which can be used in anticoagulation. Most commonly heparin and then followed by bivalirudin. These two are the most common drugs that can be used. So, being a patient on anticoagulation, there are different factors which can even patient go on to develop bleeding. So that is the reason I was telling it is a tightrope balance that we have to maintain. ECMO circulation, as we put lot big pipes, big holes, big vessels, big pipes, we put the tendency towards bleeding is also more. Bleeding like retroperitoneal hemorrhage, bleeding at the site of the cannula, so VA ECMO generally we target the ACT bit on the ear side, bleed more, and it is being the whatever the catheter being put in arterial circulation, tendency towards bleeding is more. So this has to be balanced very carefully while considering anticoagulation. As I was telling, the platelets, the center of the coagulation inverse, even this is being explored whether to give antiplatelets because they are the one which start the coagulation and being when they activate, they become they have go through the adhesion, activation, and aggregation. The platelet aggregation can lead to primary platelet plug and leading to the thrombus formation. So there are some studies where they looked at dual antiplatelet therapy, especially when we consider VECMO in the context of cardiogenic shock, where after acute coronary syndrome, these patients land up, generally they will be undergoing a stent placement where they will be put on dual antiplatelet therapy for that stent, prevent stent thrombosis. So along with that, we most of the times will be initiating the ECMO. So looking at this, generally they looked at whether any better like bleeding and all compared to dual antiplatelet, no dual antiplatelet, not much of difference. And in this study, they looked at the acute clot prevention. Probably it's better in dual antiplatelet receiving patients compared to some other indications, something like a myocarditis. Second to myocarditis patient was put on VA ECMO, probably will not be on dual antiplatelet therapy. Even the aspirin has been looked at, and they looked at electron micrograph pictures where with aspirin, without aspirin, definitely look at there is towards thrombus formation in picture B compared to picture A, where The picture A is a picture of the patient who is on aspirin. So the thrombus formation will be a bit less. So these are, of course, small center, small sample size studies. We need to explore it more. And come to unfractionated heparin, as I was talking, it is very important. Like this is the most commonly used drug and extensively literature we know and extensively studied. So it is basically what unfractionated heparin is a sulfated glycoprotein, which is naturally occurring. It's been extracted from lungs and intestines of pigs and cows, and it will not have direct anticoagulant effect. As I was telling, it actually stimulates antithrombin 3, leading to thousand-fold activation, leading to anticoagulation effect. That is the main mechanism of action. So when we start any patient on ECMO with unfractionated heparin, what is the dosing and how do we monitor? Generally, initial loading when we are putting cannulas in, so that time, so around 50 to 100 units per kg. Generally, we calculate around 5,000 for a 50, 60 kg adult. So, and along with that maintenance, around 10 to 30 units per kg per hour has to be started. And then we will be most of the times monitoring activated clotting time, which is kept between 180 to 220 seconds. And APTT probably will be monitoring initially around 6th hourly to look at whether it is really correlating well. So, which is being maintained around 2 to 2.5, 1.5 to 2 times, which is around 50 to 90 seconds. TEG, yes, if there is a possibility we can do TEG, I think this is being explored. I will be talking in subsequent slides. This can be tried. Anti-10A levels, this is actually coming up more and more, I think, being there. And this is most the standardized method compared to even ACT and APTT, which has to be maintained between 0.2 to 0.6. This is the main, the crux of how we generally go about the anticoagulation and ECMO support. So activated clotting time is being measured. It measures the intrinsic and common pathways of whole blood with all cellular elements. So the point of care testing, it's easy, bedside available. As I was telling, 180 to 220 seconds, most of the guidelines say. We'll be discussing about the lesser targets. The accuracy can be altered. That is the reason the ACT will be having limitations when there is coagulopathy, platelet dysfunction, hemodilution, hypothermia, sample site, even it depends upon sample site and size. So if there is immature coagulation system, of course, this is most common in neonates and pediatric people. But generally, other than that, there are limitations definitely associated with activated clotting time monitoring. So this is one study where it is being published in Intensive Care Medicine Journal in 2015. They explored looking at low dose heparin during extracorporeal membrane oxygenation. So their target was they looked at between 180 to 220 ACTs, and they compared with ACTs of 140 to 160. If you look at the major in this showed the major bleeding events are more with ACT between 180 to 220, and even bleeding induced deaths are more. The mortality being high, even though p value is not very significant. Major thrombosis is not much come in ACT 140 to 160. Oxygenator change did not occur frequently, even though ACT is being maintained on the lesser side. But there are limitations to this study, definitely, because they did not mention about whether they used in the circuit heparin coated circuits or non-heparin coated. What were the circuit type of description is not there, and being, I think, probably a bit small sample size, exactly extrapolating into our practice, we'll still not know. So, but definitely it's been explored without much targeting. Rather, it is a lesser targets of ACT compared to more stringent 180 to 220. So there are, yeah, of course, many case reports of anticoagulation free, especially in the context of trauma. Any patient developing ARDS, there may be associated with traumatic brain injury, and maybe ongoing hemorrhagic shock will be there. Where when we contemplate going for ECMO, probably there we don't want anticoagulation to be in place. So these are the instances where different case reports I could come across where they tried anticoagulation free without any anticoagulation. They used mostly heparin coated circuits in these situations, and even anticoagulation free lung transplantation being tried intraoperatively. These are most of the times what I looked at in these case reports. they are short run ECMOs, probably few hours to maybe few days, but later long run ECMOs probably still need anticoagulation. So another aspect what we have to look at is heparin resistance. What is heparin resistance? So the definition includes like it's a failure to achieve target anticoagulation and requiring high doses of unfractionated heparin, almost more than 35 units per kg per hour. Mechanisms most commonly are antithrombin deficiency, and there can be possible heparin binding proteins, heparin clearance increasing, and factor VIII and fibrinogen levels might be increased. So generally, how do we tackle when we get antithrombin 3 levels and antithrombin deficient is there? But most of the times, empirically, we do assume it is possibly antithrombin because that is most common. Generally, the target when we look at it is should be more than 60 to 70%. So how do we? The paradox is generally we give FFP, fresh frozen plasma. When there is a coagulopathy, we give fresh frozen plasma. But here, actually, for anticoagulation, we are giving fresh frozen plasma. So where it provides almost, I think, 1 ml of FFP provides around 1 unit of antithrombin. So we restore antithrombin. So the heparin acts better because it's indirect anticoagulation. So even there are antithrombin 3 concentrates, but they are not very much available in India. So this is regarding heparin resistance. So the investigations generally what we required, apart from like from anticoagulation point of view, what I want to say is basically we need APTT monitoring, and even we look at regularly the complete blood picture where the platelets have to be looked at. What's happening to platelets because HIT is the most dreaded complication. We have to look at the platelet trends. There are of course many other factors which lead to platelet count to go down, but still, from heparin point of view, we have to keep in mind that that has to be looked at. And at the same time, APTT, PTINR, fibrinogen, because these patients tend to develop disseminated intravascular coagulation because of various problems like underlying condition, even extracorporeal circuit itself. So we have to look at and rule out that possibility regularly. APTT has to be regularly looked at every sixth hourly, probably at least in the initial periods. Plasma-free hemoglobin is also an important component of investigation where if it is more than zero point 0.1, the safe range is less than zero point 0.1. If it is increased, definitely it indicates hemolysis. So what is it from anticoagulation perspective is basically when there is a pump head thrombosis happening, probably a lot of shear stress the RBC has have to undergo where there is a possibility that they get hemolyzed. So because of which we get plasma-free hemoglobin to be on the higher side. So this raises a possibility that there may be some underlying thrombosis, especially pump head thrombosis might be happening. So this is one indirect indicator. So coming to anti-factor 10A assay, where it is being a functional assay, as I was telling, which facilitates, it is more and more being rather than ACT, APTT, to look at the heparin function, this is being looked at. So it's a measurement of antithrombin. So antithrombin catalyzed inhibition of factor 10A by unfractionated heparin and direct inhibition of factor 10A by low molecular heparin. So these both have been can be the function of these both can be looked at by measuring anti-factor 10A. So it's basically used to guide the determination of therapeutic APTT and the clinical management of how generally we look at. So yeah, they do it. So the basics are factor 10A plus chromogenic substrate being added to the already binding of complex heparin antithrombin. So solution where the antithrombin with factor 10A will be binding to heparin. Then residual non-inhibitor factor 10A cleaves the chromogenic substrate. If you look at here antithrombin and heparin, it binds to together and then factor 10A, then it's been cleaved. So any uninhibited one will be released as a cleaves the chromogenic substrate. The chromogenic substrate which is being released being optically read. So the amount of this chromophore is inversely proportional. The more the heparin concentration, the less the chromophore. The less the heparin concentration, the more the chromophore. Depending upon that, the anti-factor 10A activity being assessed. So the different limitations of anti-factor 10A are The falsely elevated in hypertriglyceridemia, like more than 360 if it is there, and patients receiving apixaban, rivaroxaban, it's been falsely being elevated. Falsely decreased is hyperbilirubinemia, especially more than 6.6, and any substances because that can interfere with 4 not 5 nanometer absorbance light, where we pick up this anti-factor 10A chromophore. So that is the reason it's been affected in these situations. And one of this study analysis of pharmacotherapy where they looked at anti-10A versus APTT. Anti-10A compared to the ATT achieves therapeutic anticoagulation more rapidly and maintains the values within the goal range for a longer time. If you look at in these bar charts, subtherapeutic and therapeutic and supratherapeutic, the comparison is between the APTT and the anti-10A. So the anti-10A compared to APTT achieves good therapeutic anticoagulation. The monitoring of this is more helpful. So, what are the different issues associated with this heparin monitoring when we look at the different components like ACT, APTT, anti-10A, TEG, or ROTEM? So, ACT is a point of care. This is actually very easy. It's bedside available and very inexpensive, and across all centers, easy availability is there. So, but this is not a reliable reflection, as I was telling, false prolongation by thrombocytopenia, factor deficiencies, hypofibrinogenemia, and even hypothermia. And APTT is accepted means of titrating heparin. It is also being expensive, but most of the times we do send to lab. There are point of care tests also being available, but is there will be intra and interpatient variability, and the limitations are other like false prolongation. Same thing like ACT can happen. Anti-factor 10A, it's being is a specific measure of heparin and good association with heparin dose. There are definitely compared to ACT and APTT, this looks to be more promising, but of course there are some limitations for this also. PEG and ROTEM are also point of care, and they provide global function of the like coagulation cascade. Basically, it gives a comprehensive picture, but definitely limited availability across different centers is been there. So when we look at heparin, what are the advantages and disadvantages? As we were discussing, it's low cost, easily reversible with protamine, short half life. Most of the times it is the first line agent. As of now, it stands still as the first line agent. And disadvantages, as we were discussing about heparin resistant risk of it and limited bioavailability in hypoalbuminic patients and other monitoring issues. And then when we go from like heparin to other agents, have they been explored in different studies? Yes, definitely. There is a one study, prospective observed study of hemostatic alterations during ECMO, where they looked at this thromboelastometry and platelet aggremetry. So heparin 2, when we generally, I will be discussing about the direct thrombin inhibitors, but the monitoring point of view, whether the TEG and thromboelastometry as compared to ACT, APTT, and even the anti-factor 10A, whether POCT, point of care testing of thromboelastometry gives, yes, definitely there are algorithms being developed, and these algorithms help better decision making in anticoagulation monitoring compared to ACT. So what are the different options? They are there. Sonoclot is there, Rotem Tech. These are generally, these three are the one which generally we'll be looking at. So if you look at from the point of sonoclot, it is very easy to read actually compared to the signature of the sonoclot compared to others is very easy to read. So if you look at one of the pictures here before heparin and after heparin, so the prolongation of initial slows fibrinogen to fibrin reaction, there is no graph at all. So this clearly indicates that the anticoagulation is very adequate. So, and when there is hyperfibrinolysis, if there is hyperfibrinolysis, the clot formation again immediately comes to baseline. So it is easy to look at the graph and then we can apply. So one of the case report I come across, I want to just tell you. So this is a 22-year-old patient undergoing he underwent the tetralogy of Fallot surgery and then put on ECMO. The baseline hemoglobin was very high, hematocrit with 65 plus. So on cardiopulmonary bypass, they could take out 1100 ml because very high hematocrit. And then after apparent reversal, protamine, patient was wheeled out. So he was on low cardiac output ECMO. So he was woozy, still woozy, even though a lot of protamine being given. So they looked at the sonoclot analysis, and these are the various parameters that being provided in that case report. The severe metabolic and respiratory acidosis was there initially, and later it could be corrected. And there is initial hypothermia. The temperature was a bit definitely on the lesser side. And then they looked at this graph. It looks like acute dilutional coagulopathy. So generally, any patient post cardiac surgery more woozy, generally the tendency is to go for re-exploration. But being a point of care test sonoclot being done, when we look like they looked at acute dilutional coagulopathy was there, they could stabilize by giving these products cryoprecipitate and platelets, and the patient could stabilize and without wheeling in back to the operation theater. So this is how it can be helpful. So come to thromboelastography and thromboelastometry. So as like the sonoplot, it's a different signature. Definitely, I think most of the people might have come across reading about this, but it's not being very commonly available across different centers. But it gives a global assessment of hemostasis, and both of them like have different signatures, but definitely they give global assessment. So in TEG, we what we look at is R time, reaction time of to clot formation, alpha angle, maximum amplitude, which shows clot strength, indirect reflection of platelets, fibrinogen, and lysis 30, generally what we look at, which indicates a fibrinolysis mechanism. So this is the tech analyzer. So as I was telling, different what are the variables that we look at to assess the global assessment of the anticoagulation. These are the different normal ranges. If you look at the R time, reaction time, time until clot begins forming, it's generally directly associated with enzymatic coagulation, thrombin generation. Normal range is between 5 to 10 minutes. If it is less than 4, it is the blood is hypercoagulable. More than 12, it is hypocoagulable. It's closely related traditional tests are PT and APTT. So mostly it points towards the coagulation factor assessment. So the maximal amplitude, it's a maximal clot strength that being looked at, and fibrinogen and platelet function it depicts. The normal is 50 to 70, and most of the times it is being prolonged. We tend to give platelets. So lysis 30, decrease in clot strength after 30 minutes. So this indicates if the clot strength, whether fibrinolysis actively happening. So if it is more than 3%, that means excess fibrinolysis is being happening. So where generally we resort to antifibrinolytic, something like tranexamic acid. So these are the different derangement generally we come across. So this is a normal one. If there is a prolonged R time, so it indicates, as we were discussing clotting factor deficiencies, we tend to generally replace with PCC and FFP. And if it is a low maximal amplitude, it indicates platelet dysfunction, whether they qualitatively or quantitatively. Depending upon that, even sometimes giving desmopressin or platelets, we will be resorting to that. So fibrinolysis, as I was discussing, antifibrinolytics being given. So high lysis 30, if you look at this graph, is immediate taper off is being happening. So hypercoagulation, short R time, and generally this indicates a procoagulant state where probably heparin being given to prevent that. And DIC, there will be initial thrombotic phase and later bleeding phase. Depending upon that, we have to resort to different agents. So generally, what are the situations where thromboelastography is most useful? The complex coagulopathies, a lot of the interplay of different factors happening there, the usefulness of this tech is more helpful. So especially like liver cirrhosis, DIC, including TIC like trauma-induced coagulopathy, complex intraoperative coagulopathies like post-cardiothoracic surgery, liver transplant surgery, and even ECMO, where complex interplay of many things happening at the same point of time. So what are the different evidences? Is rotational thromboelastometry compared to like rapid prediction of coagulopathy and ECMO? Yes, it is an accurate and rapid tool for analysis of coagulation pathways and qualitative and quantitative platelet dysfunction and ECMO can be assessed. So platelet aggregometry can come up, but I think this is been also explored. I am not much stressing upon that. Other these three are very most of the times been extensively studied even in ECMO, like sonoclot, ROTEM, and TEG. So the ROTEM also a different signature where we look at XTEM, INTEM, and FIBTEM. So XTEM is mostly external pathway, INTEM is mostly like the internal pathway, and then FIBTEM fibrinogen levels, and the XTEM, the APTEM, most of them HAPTEM and HEPTEM, they also point towards like heparin action and all. So this is generally an algorithm where evidence-based algorithm with ROTEM. If you look at most of the times the studies I come across where the algorithm-based anticoagulation strategy compared to non-algorithm based, the algorithm based fared well. Like here, the decision is much better depending upon where the patient stands in this algorithm. The particular problem has to be can be tackled. So I think everybody can develop their own institutional based algorithm comparing with different algorithms. Probably this one algorithm I come across where they look at different variables, and depending upon that, suppose there is a fibrinolysis mechanism is in place, whether there is any heparin effect is more because of which protamine has to be given, clot firmness we have to look at, and whatever other we were discussing, probably all those can be looked at depending upon these different variables and algorithm. Come to one case report is a 40-year-old male where a severe H1N1 pneumonia with severe ARDS was there. Was put on VV ECMO support. The initial platelet count when he was on VV ECMO is 1,52,000. But on day 8, the platelet count dropped to 72,000. And of course, most of the times when the platelet count is dropping, one thing comes to our mind is most of the times hit, which is being a dreaded complication. So anticoagulation was changed to bivalirudin, and then diagnosis, of course, was supported. Most of the times, what we do is ELISA, looking at optical density diameter, the optical density levels. Depending upon that, we diagnose. But serotonin release assay seems to be the standard. Most of the times, we don't do that because it's not being available across different centers. Of course, he developed right lower limb DVT, which actually points towards the possibility of hit. So after 3 days of bivalirudin, it got decannulated, and of course, post to that was put on fondaparinux. So what clinches towards looking at this case report is hit. What are the different hit subtypes? Generally, when any patient having a thrombocytopenia and being on heparin, the clinical prediction score, 40 score, we have to look at to rule out the heparin-induced thrombocytopenia. As everybody know, what is the thrombocytopenia onset, when it happened, timing, what is that platelet count, that much borderline timing, and then whether there is any associated thrombosis and other causes pointing towards the apparent thrombocytopenia have to be ruled out. ECMO, of course, is a complex interplay where even the shear stress of extracorporeal circuit leads to platelet count to go down, but still we may have to think towards possibility of hit because being a devastating complication. So hits types, I think type 1, type 2. Type 2 is more clinically significant, and there are antibodies being produced against apparent PF4 complex. This is the reason it leads to thrombocytopenia and leading to thrombosis. So suppose when any patient we suspect an ECMO hit possibility, so then what are the different, like as we looked at different clinical prediction rule and all, once we think we have to immediately discontinue all heparin, even flushes should not be used, and switch to bivalirudin. Most commonly, that's what is available, we use. And then even argatroban if possible. Consider circuit change. That is, sometimes if it is heavily heparin coated, even though after stopping the heparin and resorting to bivalirudin, there is still possibility heparin still there in circuit, which can lead to devastating. Of course, this has to be weighed against the risk of changing the circuit. and then monitor closely for any thrombosis and bleeding. So generally, this all to be done within a 24 hours critical window. So otherwise, the mortality of patient once lands up in it is very high. Even though across literature it says the incidence of this hit is around 1 to 3%. With ELISA test, we tend to overdiagnose. Probably SRA is the gold standard, but still, even 1 to 3%, if any patient develops, it's going to be devastating. So, what are the alternative anticoagulants to heparin? So, there are many available options, but the most commonly direct thrombin inhibitors are the one we resort to. Vivalridin, as I was telling, and argatroban, hirudin, lepuridin, and as this patient was put on fondaparinux, this is post not on ECMO mostly. Post ECMO, if the patient comes out of the ECMO, generally we put on this fondaparinux. It's a easy once daily dosing. So these are all different like sources, chemical structure. I think I'm not going to discuss thoroughly. It's easily available across. So what the future? Is it time to switch to bivalirudin for ECMO anticoagulation? According to several studies, it is shows a statistically significant advantage over heparin in preventing major bleeding and thrombosis and in reducing transfusions. So some studies showed no statistical difference, but the limitation of those studies are more of retrospective nature. So probably I think bivalirudin gives advantage over heparin in anticoagulating ECMO patients. So further prospective studies are needed to make a definitive determination. So this is the different treatment strategies requiring when we go for alternative ECMO anticoagulation when the patient probably lands up in hit. So of course, this is easy. We were discussing that possibility most of the times is vivalodin. That's what we use. So compared to heparin, direct thrombin inhibitors. So most robust experiences with heparin. It can be antagonized easily if there is excess heparin effect, as with protamine, not affected by hepatic impairment. Another important component is inexpensive as compared to bivalirudin. Is more most of the times it's more costly, and but the advantage of direct thrombin inhibitors they do not induce HIT. Argatroban is more of hepatic metabolism. Bivalirudin is more of enzymatic or renal metabolism. Of course, these dysfunctions have to be looked at when we start this anticoagulation, and they are not affected by antithrombin levels. Are there any novel methods? Because to balance the bleeding and thrombosis, to prevent the different adverse effects of these anticoagulation agents, are there any novel methods being explored? Even factor 12 activation, which plays a role in coagulation pathway, being explored where factor 12A inhibitory antibody, they looked at 3F7, they say, and definitely the increasing bleeding risk is much less in these different studies. Of course, they did not look at the critical bleeding like serious bleeding, more of skin bleeding and critical bleeding and all in this study. But this is also being more and more coming into picture. And there are, of course, the most the research area in ECMO surface modification of these different circuits. So there are different classifications of surface modification, surface passivization, biomimetic surface functionalization, endothelialization. These are all different methodologies they are trying. Even if you look at different companies like Medtronic, Mackay, Terumo, Sorin, they're all trying to bond these catheters with heparin. Most commonly, even we are getting it now. And even with the albumin, human albumin, Mackay is trying, and synthetic albumin, most of the times it's being tried. And you have phosphorylcholine. So different the substances being used to surface coat so to minimize the anticoagulation dose. So even without anticoagulation, probably we don't know in the future. And very good agent is nitric oxide release polymers. This is, as they say, it is actually mimics the natural endothelium of humans. So being nitric oxide release polymers being introduced on these circuits, it's going to be like a natural endothelium like where the possibility of anticoagulation agents use can be totally minimized. is being also explored, where they looked at electron micrographic pictures. When these polymers being used, the thrombotic tendency is much less. So these are the future perspectives like circuit and device choice tailored to patient multinomic endotype. So some patients may be, as we generally discuss about the ARDS phenotypes, see ECMO patients individually also, they may be differing. So depending upon patient multinomic endotype, circuit and device can be choose. Biocompatible drug-eluting components like that we use, like in cardiology, the stents, which are drug-eluting stents being used. So this can also be tried. Real-time integrated cellular hemostasis monitoring. So continuous monitoring, something like we generally like TEG and all, like point of care, but take sample and do it. But real-time continuously monitoring this bleeding thrombotic potential uh, are also being looked at. Minimal thrombosis and bleeding without the need for systemic anticoagulation because of those circuits, and little requirement to exchange components. And by 2030, there is one study telling probably fully endothelialized circuit can come into place where anticoagulation is totally can be eliminated. So come to the end of the session almost, like take home points. While there are no gold standard guidelines for anticoagulation, but it remains vital to circuit health and mitigation of the inherent thrombosis risk. So unfractionated heparin is being, of course, still the most universal and robust studied drug, and direct thrombin inhibitors being expensive, but being they remain the mainstay. More and more people are resorting to this. And understanding of anticoagulation goals as well as the delicate balance of bleeding versus thrombosis is very imperative in caring for these critically ill patients on ECMO. Last but not the least, the physician efforts. Of course, one has to be very careful looking at all these things. Always be mindful that whether any bleeding is happening anywhere. So this is a very important thing, and looking at close monitoring of this anticoagulation targets is also plays a vital role. And as we were discussing about all different complications, one should be very careful and be mindful about that. And yeah, come to end of my presentation. So this is one stroboscope. They look at this impeller, like the pump, what is happening exactly, like even microthrombi, whatever small thrombus can be picked up depending upon like different these pictures. This is also being tried. I did not come across any time, but been studying about this. Thank you, one and all. Thank you, Srinivas sir and Ghansham sir, for giving the opportunity. I think I conclude my session. Srinivas sir.
Yes, thanks, Kaladar. I think it was a very crisp and informative talk. Now, the importance of this talk lies in the fact that while single organ failure related ECMO, like a respiratory failure or a pure cardiac failure ECMO, is a straightforward decision as far as anticoagulation and the depth of anticoagulation is concerned. But in the context of a patient with polytrauma who has lung contusions and intra-abdominal injuries, what to do? In a patient who has a leptospirosis or a renopulmonary syndrome with alveolar hemorrhages with hypoxemic respiratory failure, what would you do? In a patient who has an obstetric peripartum cardiomyopathy and also has a HELP syndrome, what would you do? These are the situations where we need to understand what Kaladar has spoken.
Srinivas, we lost your audio.
Yes, sir. Srinivas sir is not audible.
You're trying to optimize patients awaiting
Srinivas,
transplants.
you'll have to repeat that. Repeat that. We lost your audio in between.
Where did you lose it?
Leptospirosis, obstetric, peripartum,
So,
cardiomyopathy.
so,
Yeah.
so when you have somebody with an obstetric peripartum cardiomyopathy and a HELP syndrome, you probably have to understand what coagulation you need to use. Similarly, more and more patients are being put on hybrid circuits, combining ECMOs with CRRTs and liver support devices. So a proper understanding of how all these circuits impact coagulopathy is an important aspect of deciding on therapeutic strategies. And again, I'm wondering why regional anticoagulation has not actually come in a big way for ECMO as it has come for CRRT. Is probably because interruptions in the circuit can be dangerous to the patients and it can compromise the integrity of the field. This is probably the reason I think why regional anticoagulation of a membrane has not been thought about. But as Kaladhar has said, if you can endothelialize the membrane, then this problem is solved. Or if you can have a nitric oxide generating membranes, probably this problem will be solved. Then Sam, you want to add something?
Uh, just a couple of points. Just like you have the worry of the circuit and other things getting, clotted or with the oxygenator failing, there is another extreme which Kaladhar has highlighted. That is, some of these patients can go into coagulopathy. So how do we correct that coagulopathy? When would you correct that coagulopathy? What should be your, your limits of correction is also something which can be a little challenging at times. So yes, anticoagulation is, I mean, it may look very simple, put the patient on heparin and look at the ACT, but many a times it may not be as simple as we think it is. Thank you, Kaladhar.
Yes, sir.
Yeah, thank you all for joining us. If you have any queries or concerns about the topic, please do write to us, post them on the group from where you got the link from. The speaker and the moderators will attempt to answer them. Otherwise, please join us again next week for another session on the Higgs platform and join and subscribe to the Higgs website. Thank you all and see you again next week. Thank you, Kaladhar,
Thank you.
and bye-bye.
Thank you, sir. Thank you, sir. Thank you very much,
Thank
sir.
you, Kaladhar. Thank you.
Thank you, sir.